All right, well, welcome to this pharmacology drug class review in the category of anti-lipemics, or the non-LDL focused lipid-lowering drugs that specifically are targeting triglycerides, the fibrates. In this session, I'm going to explain why fibrates actually still matter, maybe not to the same degree as they did in the past, but I'm going to make it easy to understand, clinically relevant, especially in the context of patients with hypertriglyceridemia. Hey guys, I'm Dr. Busti. Thank you so much for joining us on This Is Why, a show dedicated to helping healthcare professionals understand the why behind pharmacology and the drugs that we all use every day that we see in our patients. Because when we understand the why, it makes the how become easier, and that translates into the mechanisms that go into understanding the therapeutic and desired effects that create also, unfortunately, sometimes side effects and understanding of our monitoring and counseling points that we share with our patients. Now, as with all of my drug class reviews, we cover the core content. It's the things that you have to memorize, depending on where you are in your training and experience, but those are the agents, indications and uses in clinical practice. What is the net benefit of the class? Why would I pick this? And then we kind of dive into the pharmacology to the degree that we understand it and know it, and then move to that clinical application and some knowledge points for the real world practice. All right, with that, let's jump into the individual agents. Thankfully, it's not too difficult. There's only two. These are not used as much as they were historically. That doesn't mean they have no value. But Fenofibrate and Gemfibrozil have been around for quite a while, a good portion of my career. And so I've seen them come and go in what they are used for. So when we think about indications and common uses, the primary focus is going to be on hypertriglyceridemia. All right, and specifically when we say that, we're really talking about patients who have triglycerides going to be over 400 or 500 that put them at increased risk of known pancreatitis. Now, what about moving on to our net benefit? So what does this class of drugs contribute to the overall management of patients? Well, it gets the triglycerides down, right? Especially if you need something decent with a significant reduction of 20 up to 50%, it's going to do that. Now, this says small reductions in LDL cholesterol, 5 to 20%. That is good, especially in the context of knowing that when you lower triglycerides, you are in a sense lowering the VLDL. And we know that when triglycerides get too high, that VLDL, IDL, and LDL are talking to each other. And that can change the size of the particles. Okay? It doesn't change necessarily the number of particles, it changes the size of the particles. And so that changes the LDL buoyancy. That's good, right? We want to change that. But if you can lower the particle number or the concentration in addition to that, that's even better. So it's small, and you would think, well, gosh, why are we not using them? I mean, that sounds pretty positive sounding, doesn't it? Well, that's not the way the evidence translates. So just because something sounds good, maybe is interesting, and some of it's, you need good data to support it. That's what evidence-based medicine is about. So it doesn't matter what I think or what I assume. It matters what does the data actually say. All right, so let's now dive a little bit into the pharmacology. This is where we're going to get into some of the mechanisms as we understand them and some of the effects and targets that they have, some of which I've alluded to already. All right, so fibrates are known to interact or be what are called PPAR-α agonists. And those basically are going to affect genes, expressions inside of these cells. And that reduces the overall production of VLDL. Again, I just told you triglycerides, VLDL, basically the same thing, right? And so, in fact, it's just a mathematical calculation, right? And so these drugs have also been known to increase the catabolism of VLDL in the circulation. Okay, and so that reduces the overall triglycerides, and again, you get about that 20 to 50% reduction in from the baseline in your triglycerides. Now, obviously, as the triglycerides are getting reduced, so are the interaction of the other lipoproteins, and that includes HDL. And so there is a decrease in the catabolism of circulating HDL, so it allows them to stay around longer, and which we would hope is a, again, sounds very good, positive effect on the good cholesterol that should reverse cholesterol transport. But unfortunately, it doesn't always fully still pan out in the net, right? And there's reasons for that, and I'm gonna get into that when we start getting into a couple of the side effects issues. Now, there is some limited evidence that fenofibrate in particular can reduce lipoprotein little a. Now, lipoprotein little a is one of those hidden, and I say hidden because we don't measure it as much as we should. It is being done more often now because of the awareness of this, but this is more genetically influenced. We don't have many drugs, although they're evolving, that can effectively treat this. Historically, we didn't have very many, so this was an important point. Now the evolution of this drug class is starting to, really make its way. So that's relevant because lipoprotein little a levels can be abnormal, and you can have a normal lipid profile and still have accelerated vascular disease because of that lipoprotein little a, which is like a protein molecule on the surface of the LDL particle itself. Okay, so now moving on, I would like to show you this table, and I recognize that the table is rather detailed, depending on which lectures you've heard or in this series on lipid-lowering agents, you may have already seen this, but just in case you haven't, this table is a snapshot, if you will. It's a lot of information, but it gives a bigger view of all the lipid-lowering drugs that make up the category of antilipemics and that target various components of the lipid profile. So we have it broken down by those that target the LDL, particularly their statins, and then we have LDL targets that are non-statins. In that class, you can see that there's a lot. There's ACL inhibitors, bempedoic acid, bile acid sequestrants, cholesterol absorption inhibitors like ezetimibe. You have PCSK9 inhibitors. I mean, all of those are non-statin agents that reduce the LDL, varying amounts, obviously. They're not all the same. And then we have our triglyceride targets where we have the fibrates, but you also have omega-3 fatty acids and MTP inhibitor. We also have then the miscellaneous down here at the bottom, which is niacin that affects multiple targets. All right, that's how the table is broken up into sections. And then for each of the drug classes in those sections, I give you the classic agent or representative of the drug class. Sometimes there's only one, like ezetimibe and cholesterol absorption inhibitors. And then I give you the mechanism, and then the last two columns represent the target of the lipid profile being the focus, right? So what is the target? And in this case, fibrates right here. We have fenofibrate and Gemfibrozil. And we see that the target is triglycerides in that 20 to 50% reduction from baseline. But you can also see that we have an impact on both LDL and HDL, which is what I was just talking about in the mechanism. That if we reduce the catabolism of HDL, the HDL levels should go up. And they do, okay? You heard me say that the LDL cholesterol goes down, and that's good because it is usually a concentration, but it's also a change in the size of the particles in addition to the concentration. So that's all positive things, and again, I'm giving you this so much glowing positive information of the fibrates that you're going, still, Busti, why are we not using these drugs? Well, just hold on, you'll see why, or at least the evidence will reveal some of that. Now the next image, which is far more complicated and detailed, sometimes going to be probably hard to see on the screen that you're watching. I get that, I understand that, and I apologize, there's not much I can do with trying to fit it all in here. But this is the understanding of cholesterol biosynthesis predominantly in the liver. So you can see over here the liver, and then we've zoomed in on a section of the liver And specifically, we're looking at what's going on inside the hepatocyte. So, liver has a function. Liver function tests reflect the ability of the liver to do stuff, right? One of them is to make cholesterol. And then once that cholesterol gets formed, it kicks it out as VLDL, and each VLDL has an ApoB100 protein on it. And that VLDL, again, is reflective of our triglycerides. And then there's a number of enzymes like lipoprotein lipase over here and endothelial lipase that can change the size and metabolize those lipoproteins or VLDL lipoproteins into IDL and then eventually get converted to LDL, and then they can even become small dense LDL, especially in the context of high triglycerides. We shunt the LDL down to small dense LDL, which is bad, okay? We do not want to do that. In fact, when you treat triglycerides, you improve the buoyancy and the size. You shift it from being small dense to a larger, more buoyant LDL particle, theoretically making it less atherogenic, okay? And then over here, we have the HDL doing reverse cholesterol transport back into the liver to get it out of the circulation, because this is considered the vasculature here on the side, okay? It's complicated. And I know that I didn't point to you exactly where the fibrates work, but quite honestly, there's multiple steps going on in between these steps that I can't show you. There's just not enough space without it just being a big bag of text everywhere. So I apologize for that piece, but I wanted to show you the big picture of cholesterol biosynthesis and where some of these other drugs are working, including our MTP inhibitor, right? Remember, that was one of our drugs in the high triglyceride category, that was subcategory that I was mentioning just a minute ago in the previous table. Okay, now I'm going to dive a little bit into the pharmacokinetics dynamics issues that are worth mentioning here. So unlike, okay, so not fenofibrate, but gemfibrozil in particular, is known to inhibit some phase 1 and phase 2 metabolic pathways and some transporters. The one on UGT happens to be very relevant in the context of statins, because a lot of statin medications get glucuronidated so that it can be eliminated. Remember, phase 2 metabolic pathways are conjugating drugs to make them more hydrophilic so they can be eliminated either in the bile or in the urine most commonly. And this becomes a problem for drug interactions, okay? And that's important to know, especially with statins. Fenofibrate does not do that. So if someone lumps in the fibrates, that all fibrates or fibric acid derivatives cause drug interactions with statins, then they misunderstood the evidence, okay? That's just not the case. Fenofibrate possesses some antithrombotic effects. Okay, that would be positive, right? Well, you'd think so, but unfortunately, despite these antithrombotic properties, fenofibrate has been associated with an increased risk of VTE. Remember, venous thromboembolic events. That's DVT and PE. Wow. So remember, you're getting this benefit over here in the cholesterol and lipid panel and some of the other targets, but you're also increasing the risk of VTE. So what is the net effect on there? Well, sometimes that's the problem, right? You gain one, you lose in another, and the net effect is lost, okay? And so these should not be used in a patient with a history of DVT or PE, okay? And that's a big limitation to this drug class that you need to know. One of the things that may be going on is an effect on homocysteine levels, and homocysteine is known to exacerbate this piece. Whew, it's a lot, right? All right, so that's some pharmacodynamic kinetic effects. Let's now transition to the clinical application and knowledge piece of it, okay? And let's first start talking about places in therapy. Guidelines obviously drive a lot of what we do in everyday clinical practice. And I'm going to tell you right now, I'm not against guidelines at all. I think they're great. I think they help us consolidate information. I highly respect the committees and the difficulty and the job that they have. But listen, guys, they're humans and they are a group of people that have an opinion and a particular interpretation of the evidence. And there's not always agreement. I've been in those meetings and those conversations before, and there's a lot of debate and disagreement about how you interpret. That's okay. That's a little bit of the sort of the nuances of practicing medicine and healthcare and implementation of the evidence, is that we do interpret some things differently. We do have personal experiences in our own practices that kind of bias us one way or the other. Maybe it's our understanding of other pathways and other issues going on for patients that we need to consider, and then our knowledge bases are different. All of those things play an important role in deciding that. But the committee influences the guidelines, and their evidence-based guideline recommendations, I'm not minimizing that, but it is interpretation difference. And so you've seen through the years, if you've ever studied the variations in guidelines, when those committees change, you sometimes see some pretty drastic ones. Well, one of them is about the use of evidence-based data in the guidelines themselves. They have criteria, like if it's not a randomized controlled trial with at least 100 patients, it's not being considered because that's not sufficient. Well, if you say that and you do that, that's fine. You can create that rule or parameter. But you will throw out a large portion of evidence when you do that. Well, unfortunately, drug classes like this fall in that bucket, okay? Yes, there are some studies out there, but the totality of the information is compromised. The internal validity is in question. And so they say, well, if I can't, the committee members would say many times, if the internal validity is in question, then we shouldn't use it, right? Again, debates. I just wanted you to understand that why are they considered last line therapies? Okay. Well, they're really mainly geared towards people who need isolated, predominantly triglyceride reduction. Now, some statins, HMG-CoA reductase inhibitors, can lower triglycerides, sometimes up to 20%. Okay? So you might be able to get there with that alone, right? And many times the high triglyceride patients will also have LDL problems, especially like patients with metabolic syndrome or type 2 diabetes, those kind of situations like that. Now, fibrates, if the triglycerides are over 500, where that risk of pancreatitis starts to go up, you can consider it, is what they would say, to avoid pancreatitis after, that's a key word right there, after addressing dietary, alcohol, carbohydrates, those kind of things, right? So it's kind of like your last-ditch effort. But I wanted you to understand the context as it relates to the place in therapy. You might still see patients on them, but you're not going to see many patients started on them anymore, okay? Who should we be careful with? Well, patients with CKD, we need to be careful with. There is some renal elimination. There's debate about that and renal dose adjustments. Gallbladder disease. These drugs are known to cause gallstones, cholelithiasis. And so what happens is these can cause cholecystitis. But if patients have their gallbladders removed, then it's really not an issue. But I bring it up. Patients with a history of either active or history of VTE. So that would be a DVT or PE, right? And then it says plus or minus myopathy here because these drugs have been associated. Case reports concerns about muscle aches and pains. Well, many of these drugs were used in combination with a statin medication, which if you're using Gemfibrozil being that it inhibits UGT, was known to increase the glucuronate or inhibit the glucuronidation of the statins, which we know statins have a dose or concentration dependent effect on the muscle. So which one? It's hard. It's really hard. All right, Fenofibrate comes in a lot more dosage formulations compared to Gemfibrozil. Different various salts, dosage formulations. to basically try to improve the overall bioavailability and reduce the frequency of administration throughout the day. So Gemfibrozil, you'll see it is dosed twice a day by mouth. Many times, patients can't tolerate it. It's supposed to be taken on an empty stomach. All this stuff, and these phenofibrate formulations, are help there to improve that. Not only make it once a day, but some of these formulations can be taken with food, which most people would want to do. Again, Gemfibrozil is twice a day, typically on an empty stomach. That's harder to tolerate, but to maximize the oral bioavailability, you should take it on an empty stomach before a meal by at least 30 minutes to minimize that effect. But many patients mix it, and that's just the way it is, and that's the only way sometimes you can get it down, but it is the way it's supposed to be administered if you end up using it. Now, going back to the cholelithiasis, if somebody does develop stones where they already have existing stones, don't even start it, right? But if they start to develop these stones, you should probably back off and stop that. Again, the hematologic effects can extend even to the CBC, where the hemoglobin hematocrit can sometimes see a small decrease. Clinically, not that relevant, but again, in somebody who's anemic to begin with, it could be an issue. Myopathy, rhabdomyolysis, again, those definitions are very important. I discussed that in my lecture and topic review on HMG-CoA reductase inhibitors, where it's typically more common of an issue. But remember, these risk factors are going to be more likely to happen when co-administered with a fibrate, either one of them, but specifically Gemfibrozil because of the drug-drug interaction due to, again, Gemfibrozil's ability to inhibit glucuronidation-mediated metabolism of those statins that reduce the overall elimination of the drug from the body. Also, again, Gemfibrozil is known to affect transporters, and we know that some transporters can be useful by the statins for elimination. This table, which I also use in the statin lecture, is looking at the difference between fenofibrate and Gemfibrozil and their overall impact on the drug concentrations, whether it be the steady state concentration Cmax or the area under the curve, for each of the individual statins. And you can see across the board, the problem's not fenofibrate. The problem is Gemfibrozil, and it's several-fold increases. And so the reason that matters is it goes back to the risk factors of knowing that the risk of hepatotoxicity and myotoxicity is due to concentration-dependent effect. The more drug exposed to these tissues, the greater the risk of developing these adverse reactions and side effects. Now, Gemfibrozil, again, liver enzymes, it is possible, and there's also this main concern of a possible, and these drugs just getting hammered. But if you think about the potential risk of malignancy, potential risk of VTE, increases in homocysteine levels, well, you're losing those benefits on the lipid profile that seem all very positive in the directions that you would want. So there's been some other studies that have been done that basically showed they're basically neutral. But once a black cloud starts to hang over a drug or a drug class, it becomes difficult at that point to try to remove the cloud. All right, so what about monitoring? Well, obviously a lipid panel, you're treating triglycerides, especially when they're over 500 and for sure over 1,000. So that compromises sometimes even the ability to determine what the LDL is, depending on how you measure it at your institution, because some of institutions don't do direct LDL assay. Some still, rarely do the calculation. The liver enzymes issues in the function is about, again, if you still have a gallbladder and you develop cholelithiasis, that leads to cholecystitis, which would raise the concentrations of AST, ALT, ALK phos, and be suggestive of gallbladder or biliary disease in those patients. And as I mentioned, CBC might be done to assess the trends of hemoglobin hematocrit, especially if somebody has underlying, anemia. Now, the last thing, and is worth noting, I would highlight this, I would star it like I just did, is the serum creatinine. One of the problems with these drugs is that they can, and it's really mostly with Gemfibrozil, see, it just keeps getting beat up. But they've been shown to increase the serum creatinine. Now, here's the thing. It's not damaging the kidney. It's not because of that, right? So it's not a compensated or accompanied by a significant change or a decline in the glomerular filtration rate, or GFR. It's just a bump in the creatinine. And so we see it with Fenofibrate, we see it with Gemfibrozil. I'm sorry, it's actually more common with Fenofibrate. I said Gemfibrozil. It's actually more common with Fenofibrate. See, it's got to keep it straight. The problem is both of them do it. But Fenofibrate has been probably a bigger culprit. And so people don't understand that it's not really worsening the GFR, but they don't like that on their records, and they don't like to see labs. So we always should interpret labs in the context of the whole patient, what's going on. We should also consider medications that are known to modulate the activity. Some does similar things, right? So it's not impossible for this to happen. Now, patients who develop hypertriglyceridemia, commonly you'll see this in HIV patients, especially on protease inhibitor-based therapy, classic cause for hypertriglyceridemia. So you're stuck, right? I mean, what agents are you going to use? You got fibrates, you got omega-3 fatty acids, and both have been studied. But the problem is that you got to be careful with them, especially in patients where there's a risk for drug interactions. And raltegravir is one of the integrase inhibitors. It's not a PI, but it's one that has been associated with myopathy. Well, these drugs have also been associated with some myopathy. So when you got to be careful with them, because you don't want to affect the compliance adherence to the antiretrovirals that could compromise the overall control of the HIV. All right, trying to wrap things up, and let's pull this together. So the fibrates, that makes up Fenofibrate Gemfibrozil, right? That's that class. They primarily are used for hypertriglyceridemia, especially when the triglycerides get over 500 and for sure 1,000. We don't want those patients to develop pancreatitis, right? The mechanism is unique. PPAR-α agonists. It's going to affect the production of VLDL and change the output of VLDL from that liver. Remember, and VLDL gets metabolized and converted and interacts with other lipoproteins. It also impacts the catabolism of VLDL, okay? And so those two are the reasons we see that reduction in the triglycerides, maybe even as high as 50%. Unfortunately, despite the targets of those lipid profiles that we get some benefits from, it's associated with VTE, gallstones, myopathy. I mean, raises in the serum creatinine, especially with Fenofibrate, seeing changes in labs. People just don't like to monitor and have problems, especially like that, even though they're really not damaging the kidneys like we were talking about. So I hope that you understand the use of Fenofibrates in the context of the evidence, where they recommend, why they recommend them so low on the totem pole of options, that you understand why and where this drug's benefit really resides in these patients with high triglycerides in particular, and maybe you don't have other alternative options. So I hope you found it to be useful. I hope it was put in the proper context where you can apply it clinically in an appropriate context of the evidence, okay? Please join us on YouTube. If you're not a subscriber, please give us a like, click the bell so you can be aware of new topics that are being there. We really would appreciate your support and giving us a like. And this stuff helps, right? So that we can continue to invest in each other and provide you these kind of resources. So thank you for joining me. I'm Dr. Busti. Never stop learning. Why? Because it makes the how so much easier. I say that a lot, but it's so true. And I wished I would have been taught some of that perspective early on in my career, but we're doing it now. So thank you for joining me. Take care.